another interesting and often less discussed topic on neuroendocrine pancreatic cancer. And we've got Dr. Alan Anthony on screen. May I request our chairpersons for the session, Dr. Sheila Mitro, radiation oncologist, Apollo, Kolkata, Dr. Shubroto Saha sir, radiation oncologist, Apollo, Kolkata, and Dr. Vikas Kumar Agarwal sir, senior surgical oncologist at Apollo, Kolkata, to come over to the stage and chair the session. Over to you, sir and ma'am. Please introduce the speaker and start the session.
Thank you. To save the time, we will move on to the session itself. And we have a renowned personality, Professor Alan Anthony from Leeds, to discuss on the neuroendocrine tumor management, pancreatic neuroendocrine. So over to Alan.
Thank you very much. I'm just checking. Have you got my slides there?
Rahul,
Yeah.
can we have Alan's
Yes,
slide on the
sir.
screen,
Should we
please?
display it, sir?
Not yet, Rahul.
So just a second.
So I'd like, just while that's happening, so I'd like to thank very much the faculty for inviting me to talk about pancreatic neuroendocrine tumors and their management. And in the spirit of the whole conference, I thought I would focus on some aspects of pancreatic neuroendocrine tumor management which are controversial and probably haven't yet reached consensus. And it's because, being rare tumors than pancreatic neuroendocrine tumors, there's a relative lack of good clinical trial data to actually guide our practice. Next slide, please. So I was going to pick three topics. One is and as a non-radiologist, but as an oncologist who deals with neuroendocrine tumors, the difficulty with imaging of pancreatic neuroendocrine tumors and all the problems that arises. Then talk a little bit about management. So we've got a number of treatments, but we're still not quite sure what's the best sequence. And finally, something that I'm sure everyone who deals with pancreatic neuroendocrine tumors or pancreatic tumor boards finds increasingly: what would we do about the small incidental pancreatic neuroendocrine tumor? Next slide, please. And you might be asking, well, why talk about pancreatic neuroendocrine tumors? Because they're rare. So if you look at the data here from the American SEER database, there's been a significant increase in the incidence of pancreatic neuroendocrine tumors over the last 20 to 30 years, with certain inflection points showing an even steeper rise. And in the UK data, if you look at the bottom graph here, and this is all neuroendocrine tumors, again, over the last 20 years or so, this yellow line here, which doesn't show up very well, this is the pancreatic neuroendocrine tumors. So again, there's been a significant increase in the incidence of pancreatic neuroendocrine tumors. So it's something that we're seeing more frequently and having to deal with. Next slide, please. So as I say, the controversy is what is the best imaging method to use in the diagnosis and surveillance of pancreatic neuroendocrine tumors, and how many different imaging modalities are actually required to get the best treatment for patients. Next slide, please. So obviously CT scanning is the workhorse of all oncology, and it's usually actually where often neuroendocrine tumors and pancreatic neuroendocrine tumors are picked up. But the problem with neuroendocrine tumors in general and pancreatic neuroendocrine tumors specifically are the tissue density is very similar to the tumor, the organ from which they arise, and the vascularity of the tumors, they can be hypervascular or hypovascular. And so the actual mode of CT scanning can make a huge difference in terms of what we see when we get the results. So for example, in a non-contrast scan, thankfully somebody's put a little arrow in here, you can see there's a tumor in the tail of the pancreas with some calcification, which shows up a bit easier on an early arterial CT scan phase, but in the portal venous phase looks completely different. And we know that the sensitivity of CT scanning for pancreatic neuroendocrine tumors can be as low as 60%, depending upon the size of the tumor and depending upon the vascularity. Next slide, please. Perhaps more importantly is actually when we're dealing with metastatic disease, and this is something that happens very frequently, in that if we take it from C back to A, if you looked at this CT scan of somebody with a pancreatic neuroendocrine tumor that's metastasized to the liver, you can see that there's some indication of metastatic disease, but it doesn't look as though there's a very large tumor burden. Whereas if you do a dual phase contrast in the portal venous phase, more of the lesions pick up. And then in the arterial phase of the scan, there's a significant tumor burden with a lot more disease. And the problem is that, and certainly in our institute, and I'm sure we're not alone across the world, even sometimes when you have two arterial phase CT scans that have been reported as arterial phase, very subtle differences in the contrast through the liver can make a big difference in what we can see in the CT scan. So it can sometimes be very difficult to tell whether a tumor is progressing or it's stable. And therefore, we nearly always have to take our scans back to our tumor board to get our expert radiologists to deal with the phase, deal with neuroendocrine tumors, because it can be very difficult sometimes to know what's happening to the tumor. So CT is what we all have, but it's got lots of issues related to it. Next scan, please. Oh, sorry, next slide. So what about MRI scanning? Is MRI better? Well, again, looking at a tumor in the tail of the pancreas, you can see in the different scanning phases on CT, whereas in the liver, when you do a diffusion weighted MRI scan, a liver specific MRI scan with diffusion weighting, this is the best method of looking at the liver and shows up an awful lot more in the liver in terms of metastatic disease than CT or even non-liver specific MRIs. And so certainly one of the things, and particularly this can be very useful in lots of patients now who have fatty liver and fatty liver after chemotherapy. If there's an accumulation of fat within the liver, it can be very difficult to image the liver with neuroendocrine tumors. The problem is that MRI scans are fewer than CT scans, and they only focus in certain parts of the body rather than the whole body. So there are certainly patients who you need to do an MRI scan and a CT scan, and that obviously builds up the cost and the inconvenience for the patient. Next slide, please. So neuroendocrine tumors particularly are very heavily reliant on functional imaging, and the functional imaging can have certain specific, has importance for the management of neuroendocrine tumors. So the functional imaging predominantly based on the fact that neuroendocrine tumor cells or neuroendocrine cells have somatostatin receptors on the surface, and somatostatin receptors 1 to 5, with different ligands such as octreotide binding strongly or less strongly to the different receptors. So if your neuroendocrine tumor cell expresses somatostatin receptors, it should bind these ligands like octreotide or pentetriotide, and you can radio label them, and this will show things up. And since 1994, using indium 111 pentetriotide and the octreotide scan, that has been the beginning of functional imaging in neuroendocrine tumors. But we know that that's not the most sensitive method. And in the last 10 years or so, the use of new PET tracers using a positron emitting isotope gallium-68 bound to these various somatostatin receptor binding molecules is far more sensitive. All have been shown to have similar clinical effectiveness, but they're all more sensitive than octreotide scans. And as you can see from this graph or this figure here, looking at the liver, you can see there's some uptake on the octreotide scan, but when you do the gallium-68 dotatate PET scan or DOTATOC PET scan, you get an awful lot more sensitivity and a lot more lesions showing up. One of the problems about the octreotide scan in pancreatic neuroendocrine tumors is in the case of insulinomas, because insulinomas, only about 50% of insulinomas will show up on an octreotide scan. And although with a gallium PET scan, because many insulinomas, particularly small ones, don't express somatostatin receptors, that sensitivity comes up to about 85%. One interesting point to note is that there are other tumors and other benign conditions that will also express somatostatin receptors. So I've certainly been caught out in the past with a patient who had tuberculosis and a large tuberculoid granuloma, which showed very strongly positive on an octreotide scan. And other tumors such as small cell lung cancer, but also renal tumors and cholangiocarcinomas can sometimes show up as well. So we've got to be aware of that. Next slide, please. But the main point of this part of the talk I wanted just to touch on was, can functional imaging actually give us any indication as to the biological behavior of our neuroendocrine tumors? So there's an increasing interest and trend to say, well, what role does 18F fluorodeoxyglucose PET play in the role of neuroendocrine tumors. So the perceived wisdom till now is that well-differentiated, well-behaved neuroendocrine tumors, you should scan them with an octreotide scan or a gallium PET scan. And the grade 3 neuroendocrine tumors heading off towards the kind of the smaller cell end of the spectrum, because they're metabolically much more active, then we should use FDG PET. But can FDG PET tell us anything about the biological behavior of the grade 1 and the grade 2 neuroendocrine tumors? And if you look at this image here, this is the gallium PET showing lots of uptake and activity. But when you do an FDG PET, some of these lesions also show up in the FDG PET. And could that be saying that they potentially are more metabolically active and therefore perhaps are likely to have a worse outcome? So from the Royal North Sydney Hospital in Australia, they came up with this net PET score where patients had a gallium PET and an FDG PET done within about a month of each other. And depending upon the SUV levels, the uptake of the binding of the gallium or the uptake of the FDG, they made a score for those where it was strongly gallium PET positive, but with no uptake in FDG PET, right up to the opposite, where they were strongly positive in the FDG PET and negative in the gallium PET, and then various differences in between for those that took up both receptors. And when they looked at that in terms of survival, so this is the F1, this is the strongly octreotide positive, this is the strongly FDG positive, and this is the group in between. You could start to differentiate patients in terms of their likely outcomes. So it might be that this, using these two functional imaging techniques, might be able to give us better prognostic behavior. Next slide, please. And in a similar way, this is the group from Bad Berka in Germany, where they looked at a much larger number of patients, including pancreatic neuroendocrine tumor patients. And this was saying, could FDG PET give an indication as to the likely benefits in such patients from giving targeted radiotherapy? So all of these patients had gallium 68 PET positive tumors. They were all going to receive targeted radiotherapy using Lutathera, but those patients who were FDG positive had a much worse overall and progression-free survival than those patients who were FDG negative. So again, it might allow better selection of patients, and some patients who the targeted radiotherapy may not be as effective. This is all retrospective data, unfortunately. There's no prospective studies, and as yet, looking in clinicaltrials.gov, I could only see 2 small studies currently running in Canada to try to look at this. And just asking my nuclear medicine colleagues, the problem is doing 2 scans regularly. So an FDG PET scan probably costs about 80,000 rupees NHS prices, whereas a gallium PET scan costs about 150,000 rupees. And if you were going to do that in every patient you had coming through, again, certainly in the National Health Service in the United Kingdom, we would want very strong evidence to know that this was really benefiting patients. Next slide. So the next question is, what's the best treatment to give for pancreatic NETs, and what's actually the optimal sequence? Next slide. So for well-differentiated pancreatic neuroendocrine tumors that are positive on an octreotide scan, we know that the somatostatin analogues, octreotide and lanreotide, can, as well as controlling hormonal symptoms, can also have a disease-modifying effect. And in the Clarinet study, which is now 10 years old or so, for patients who had slowly growing disease, so these weren't rapidly growing tumors and they had a Ki-67 of less than 10%, there was a definite progression-free and ultimately overall survival benefit in patients who had lanreotide. And this study, as opposed to the PROMID study, which didn't include pancreatic neuroendocrine tumor patients, but certainly shows for pancreatic neuroendocrine tumors, that this is and I think most people around the world for slowly growing PNETs would probably use a somatostatin analog in the first line. We also know for slightly more higher grade tumors, with those with a Ki-67 greater than 10%, again, somatostatin analogs are beneficial with a median progression-free survival of 11 months, with good prognostic features being a low liver tumor burden and grade 2. And even in people who were progressing on lanreotide 120 milligrams, if you doubled the dose by halving the frequency of injections, again, you could still regain some control. So the somatostatin analogs are definitely effective treatments. Next slide, please. And what about chemotherapy? Well, again, pancreatic neuroendocrine tumors, as compared to many other neuroendocrine tumors, have good evidence behind them showing that chemotherapy can be helpful and be effective. And there's a range of chemotherapy drugs. The current international standard seems to be temozolomide and capecitabine, but in the past, we've also used streptozicin and lomustine. So a combination of an alkylating agent and a fluoropyrimidine seems to be beneficial to many patients. This was the original TEMCAP data from Matthew Kulka, showing a really impressive waterfall plot, and then some pictures where you get remarkable responses to chemotherapy. Next slide, please. And then we also have the small molecule TKI inhibitors, the mTOR inhibitors. So again, this is randomized controlled data from some time ago. So all these patients had progressed upon somatostatin analogs. But with sunitinib, again, we could show that by being in sunitinib, there was an overall survival benefit compared to placebo, with a very impressive progression-free survival benefit. And I'm sure everybody who treats pancreatic neuroendocrine tumors have had a few patients. I got one lady I saw yesterday who's had stable disease for 7 years on her sunitinib, and the same with everolimus. Again, these were all patients who had progressed in somatostatin analogs, and everolimus had a significantly improved progression-free survival. But the question has been, well, actually, we've now got chemotherapy, we've got TKIs and everolimus. Which treatment's best? Which one should we use after progression on somatostatin analogs? Next slide, please. And so this study that was presented at ESMO in September last year in Paris, run by Professor Ramon Salazar in Barcelona, was the SECTOR study. And this was a study saying that in patients who had progressive disease, it was a randomized crossover study by patients starting on everolimus and then switching over to streptozicin and 5-FU as the chemotherapy, or the other arm B was patients starting in chemotherapy and on progression switching over to everolimus. And this was an interim analysis of the results of the first progression-free survival. So was there a difference between either of these treatments in controlling the disease longest when used as a first-line salvage therapy after somatostatin analog treatment? And you can see from here that there was really very little difference. Both had a non-significant difference between the arms in terms of the primary endpoint, which was 12-month progression-free survival. However, you can see again, there's more patients in this arm. So it's about, I think it was over 20% of patients had actually a response in terms of complete response or partial response, whereas it was only about, this was about 30%, where it was just as about 11% of patients with the everolimus had any shrinkage of the tumor. So the take-home message from this trial was that if you needed tumor shrinkage from symptoms, either bulk symptoms or from hormonal symptoms, or patients were just unwell because of the progression of their tumor, then you were probably better off starting with chemotherapy. But we're still awaiting the survival advantage to see if there's a difference between the sequencing in terms of overall survival. Next slide, please. And again, we also know that many of these patients will be positive on octreotide scans or gallium scans and would be candidates for PRRT. So is there a difference in terms of patients progressing after somatostatin analog therapy who would be candidates for targeted radiotherapy? Are you better giving them the targeted radiotherapy first, or are you better giving them something like sunitinib? And again, Eric Bodan from Gustave Roussy presented at ESMO a study called OcuLrandom, in which half the patients went on to receive lutetium dotatate and the other half went on to sunitinib. And it wasn't a comparative study trying to find out which arm was best, but it was seeing whether they met a predefined endpoint to say whether it was worth considering taking on or whether it looked as though it might be a treatment that was beneficial. And there was a definite trend towards PRRT treatment being more effective as a second-line treatment in these patients rather than going on to sunitinib. And because there is some evidence to say that the more treatment, particularly chemotherapy treatment you have before using targeted radiotherapy, might increase the risk of bone marrow toxicity down the line in terms of myelodysplastic disease or leukemias, then it might be that we need to use this treatment in certain patients sooner rather than using other chemotherapy drugs or molecularly targeted agents. Next slide, please. And then finally, and hopefully quickly, because I know we're running out of time. So increasingly, I remember the graph from the very beginning showing the incidence of pancreatic neuroendocrine tumors rising rapidly. The reason for this is as more and more of our patients have CT scans, we're picking up more and more small incidental pancreatic neuroendocrine tumors, which may have been there for years beforehand and not caused the patients any symptoms. But once we've detected them on scans, we don't know what to do. And so it's a big debate at all our tumor boards is to say, should we operate? Should we keep them under surveillance? What do we do about them? Next slide. And this is what we're talking about, these small incidental pancreatic nets. And as I say, there's been a significant rise in the small nets from 12% to over 20%, and that's up to 2009. And I'm sure that's much higher because of this increase in CT scanning. So the international guidance from ENETS and the NCCN base their decision-making on size. So above 2 centimeters, they suggest that patients should undergo surgical resection. But if you've got a PNET, a small PNET in the head of the pancreas, that's a pancreatic duodenectomy and a lymphadenectomy, which is not a minor undertaking. For those tumors less than 2 centimeters, then it's a lot less certain, and they say, well, you need to have a discussion with the patient. Next slide, please. So really, does size make a difference with pancreatic neuroendocrine tumors? And this American epidemiological SEER data covering 50% of the United States would seem to suggest that at all stages of disease, whether localized or regional or even distant, the larger your tumor to start off with, the worse your outcome. But the problem with this data is that it's epidemiological data. It's not prospectively collected trial data. And there's lots of confounding factors. So many of these patients had surgery. Many had metastases to even start with. Some had high-grade disease. And we can see from this part of the data that this was above and below 2 centimeter patients who'd gone on to have surgery. The cancer-specific survival wasn't different, but the overall survival was different because for people who didn't have surgery, because many people who didn't have surgery because they were elderly or they were unfit. And so therefore you can't really take size as the major defining principle. Next slide, please. So this was a meta-analysis looking at small studies. So there wasn't many patients in these studies where patients with pancreatic neuroendocrine tumors that had been detected incidentally had been put on surveillance rather than going straight to surgery. And essentially, although the numbers were small, this suggested that there wasn't really any detriment to patients by undergoing surveillance, that if you underwent surveillance and the tumor continued to grow, then surgery at that point was equally as effective in getting rid of the disease, and there wasn't an increased risk of metastasis. Next slide, please. And this is a really interesting Canadian study where they looked at tumor growth rate depending upon initial size of the tumor. So people who were kept under surveillance for a variety of reasons, obviously most of these tumors were less than 2 centimeters in size. But what they showed was that even larger tumors, some small tumors grew very rapidly, some larger tumors actually got smaller in size. So size itself isn't the critical thing. It's much more likely to be other biological parameters of the tumor that are important in determining how they behave rather than initially size. Next slide, please. And thankfully, we've had the ASPEN study. So the ASPEN study, a study led by Massimo Falconi from Italy, was trying to answer this question. So it was a 1,000-patient prospective observational study, impressive that it ran through COVID, and basically individual institutes could decide whether they would operate upfront on pancreatic neuroendocrine tumors or they would keep them under surveillance. And they were looking for, it was a very systematized way of following patients up to try and get information as to what was the best approach. Next slide, please. And this was an interim analysis, so a very early analysis. But basically, the 406 patients who underwent surveillance, that the majority of these, and these all had EUS-guided biopsy to start with, so the majority were grade 1, they were generally small, and a very few on the radiological staging had lymph nodes. In the surgical group, and again, this is the preoperative analysis, far fewer patients had endoscopic ultrasound-guided biopsy because they were going to go on to surgery. So there seemed to be perhaps a higher number of grade 2 and even some grade 3 patients. But post-op, in fact, there was still about the same number of grade 1 patients, and there was one patient who had a higher grade tumor. So I suppose what that says is surgery can occasionally pick up those patients who have a higher grade. But what they showed was, in fact, there wasn't really any difference so far in the progression-free survival between patients who were kept under surveillance as opposed to patients who had undergone upfront surgery. Again, probably saying that there's no harm to patients if you keep them under surveillance initially, although the problem is what we don't know is how long patients do need to be kept under surveillance. And for younger patients, that could be decades. Next slide, please. We do know that by doing EUS-guided, endoscopic ultrasound-guided biopsies from this, that tumours less than 2 centimetres in size and who then go on to have resection, that the grading of the neuroendocrine tumour got by biopsy is very highly concordant with that got from surgery. So for small tumours, doing an EUS-guided biopsy will give you a very good indication as to the grade of the tumour. And it's probably the grade of the tumour that's more important than the actual size of the tumour. Next slide, please. There's an interest in whether we can use EUS-guided ablation rather than surgery to get rid of these tumours. And these are some small studies done which showed, again, that fact for many tumours that were ablated, and that's certainly a technique used for tumours that are producing hormones and that can't be operated upon and are quite symptomatic. But it probably also allows us to have long-term disease control with relatively modest side effects. Next slide, please. And then in terms of surgical options, there's a debate regarding whether patients should have minimally invasive or open surgery versus enucleation. And obviously enucleation is advantageous because it's less traumatic for the patient, but it doesn't remove lymph nodes. And there's always a concern that if there's lymph node metastatic disease or micrometastatic disease, that might be what causes recurrence in the patients. Next, please. Next slide, please. And this is the last slide, and it probably doesn't show up very well. But basically, this was the difference between those patients who underwent enucleation and patients who underwent open surgery, depending upon size. And the 5-year overall survival rate was really almost not different at all. So I think that says that for patients who do need surgery, that enucleation, if it's possible, is as equally as safe as doing a major operation. So I'm sorry to have rushed through that at a high rate, and particularly the last bit about small pancreatic neuroendocrine tumors, because it's still we still discuss it at our tumor board on a regular basis, and I don't think we really have an answer to that. But I hope it's shown some of the controversies around pancreatic nets, and I'm happy to take any questions. Thanks.
Thank you, Professor Allen, for a lovely coverage of neuroendocrine tumor.
I think we don't have any questions.
Okay.
So thank you, Alan. Thank you for the excellent talk and your valuable time.